Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
Hello, everyone. Welcome to another episode of the Inside the Boards podcast. This is another segment of our addiction podcast series. I'll be your host today. My name is Mariah Siddiqui. I have with me Dr. Stewart Bryant. How are you doing today?
Doing great. Enjoying the little holiday break we've got here and hoping to get some recording done.
I hope you had a good break and holiday, and hopefully you and your family are safe from everything.
Yeah, same for you.
Thank you. So today we'll be discussing opioids and opioid addiction. So do you have any thoughts on this topic before we get started with our questions?
Yeah, absolutely. So, Mariah, the opioid addiction and the opioid epidemic are a hot topic, I guess, in medicine. You know, if you're in medical school right now, you've probably had lectures on opioids and opioid addiction in particular. And, kind of a while back, you might not have heard about opioid addiction. It wouldn't have been a concern even in medical school. But as more and more information has kind of come up and more people have been dying from opioid overdoses and then subsequently other medication overdoses related to opioids, it's kind of become a major problem in the United States and, around the world. The U.S. is a particularly bad location because we are one of the highest. I think we are the highest prescriber of opioid medications, and we get the medications into these people's hands, and then we don't do a good job with getting them off of it as well. So it's definitely a problem. It causes a lot of morbidity and mortality. And, I think it's equivalent to, in my medical school, I think I learned about 40,000 people die every year related to opioid and drug overdoses. That's a tragedy. And there's a lot that we can kind of do to really protect people against this and try to fight the urge to get people hooked on these drugs. I know nobody prescribes this medication with the intention that that's what's going to happen, but people need to be aware that when you're giving these drugs to people, that's one of the potential options, and it's got a heavy potential, especially with people who have previous histories of addictive disorders or substance use disorders.
Yeah, I agree. And you're right that more than 40,000 people died just from overdosing on opioids. I think in 2018, there was like 47,000 people. And a huge majority of that was actually from prescription medications and not just off the street. So that's kind of scary because you're right. We're the ones giving these patients these medications for their pain. And when I was doing research on this topic, I saw that in the 90s and the early 2000s, there were studies that showed that opioids weren't addicting, which is why they became such a huge drug to prescribe to people for pain, for short-term and long-term pain. And then now we're kind of suffering from those studies that weren't properly done because now everyone's being given opioids for any type of pain.
Yeah, it's one of those things where people were given the medication and they were told that this was safe and a unique and powerful tool for making people, reducing their pain. The pain is the fifth vital sign kind of campaign took off around the 1990s as well, early 2000s, where, we had to start rating everyone's pain and knowing you need to be treating people's pain. It's not enough to take care of their disease or cure them or help them with what they're going through. If you're not treating their pain, you're not doing a good enough job. And that was that was the story that we were told. And, now, not to say that that's not true, but to put such a heavy reliance on treating pain may have done us a disservice to, the public who thinks that they should not experience pain, and the physicians who feel like they're compelled, like they almost have to take care of someone's pain in order to avoid, medical malpractice or anything. And this was really led by the Purdue Pharma. I don't know if you're aware of them in the news, but they're one of the first prescribers of opioids, and they marketed them as non-addictive. So these started to get really, really pushed as a pain medication, and the pharmaceutical industry made a lot of money off of it, and really kind of avoided taking massive penalties until just recently. Even now, like the settlements that are made against pharmaceutical companies isn't really impactful compared to the costs that they've really had on the population.
Exactly. And I think like over or close to like 500,000 people have died since for the past like decade or so, according to the statistics that I was reading, which is a lot of people. 500,000 people is a lot. And I'm glad that they're finally going to be held accountable for what they did. Do you have any thoughts on why opioid addiction is such a huge thing in specific groups of people, depending on the location or the area? Or do you feel like it's just an overall, like everyone can get addicted to it? Do you have thoughts on it? Like, is there any genetic component behind addiction? Any other sort of like socioeconomic relation or correlation?
Yeah, I mean, all of those, we tend to do a lot of these studies where we look at demographics and we see who are the people most at risk. And then typically the people of certain ethnicities, Black, Hispanic in particular, and then people with lower socioeconomic demographics, the poor, those who can't afford good medications, good treatments, to spend time even going to see the doctor. Those are definitely the people that are most at risk. So I work in San Francisco right now. There's a large homeless population. And if you pass them on the street, a lot of them are just peddling drugs out in the open. And it's a real tragedy to see. And you don't feel safe in particular, but you know that they're not in a position to really be getting help. And to be honest, getting help is honestly that's a higher cost than just continuing the habit. So, the system's not really set up to protect people once they've become addicted. And, we do have services. There are rehabilitation services. There is counseling services. There are detox services. But, some of those take time, they take effort, they take money, and they take a certain willpower. And a lot of people, really aren't able to have those resources to even begin with. So from the perspective of who gets these and how they get affected, the worst case scenario is going to be the person that has been injured. They require the medication for a brief period of time while they have their injury, or potentially after surgery, and then they fall off the doctor's radar and they just end up getting medications from other people. They get them from the street. They get things like heroin and fentanyl to kind of substitute their pills that they were previously using. And, we really don't have any way to keep them accountable and stay in touch to kind of get them the help they need anyway. So I work in orthopedic research. I deal with, a lot of surgery patients who are on narcotic medication for a brief period of time. And, I've seen a number of those cases where the patients are contacting me in, a lot of pain, and they've been on the medications for months now, and they just don't feel like they're able to come off. And, when they talk to you about what they're experiencing, you can tell that they're detoxing, and that's why they need the pain medication. It's not just that they're in pain. It's, they're having all of these withdrawal symptoms, and they feel like, they just need the medication to get them through the time period that they're in, and then they'll handle it. And for a lot of people, they'll just never get the time to really handle it, even though they'll say something like that. And you try to help them, and eventually you have to cut them off. And if you haven't gotten them the resources they need, they can turn to other less official routes of getting the medications and, eventually end up in really bad places.
Exactly. It seems like a vicious cycle of some sort where you can't fully take them off right away because of their pain and their withdrawal, but also the more you give them the medication, the more addiction that the more addictive they get. So I just have a question. So in your work, when you have a patient, what would be the indications for you to prescribe opioids? Which medications would you prescribe? For how long? How do you gauge that when you have a patient who's in pain?
So yeah, it definitely depends on where their pain is coming from. If they are like a long-term pain patient, they've had pain medication for years, they follow up with a regular like primary care physician. I typically like to let the primary care physician handle that kind of medication use, just because it's much safer for them to do it and manage it, because they're going to stay in reliable contact. They can identify if there's a problem and they can get them the help that they need. Working in surgery, I feel like we work with the patients for a briefer period of time. So if someone comes to see us as a new patient and they're looking for pain medication, they've got to be a candidate for surgery. They probably need to be following up with us pretty regularly. And the goal would be to get them through the pain until they get surgery, and then through the pain after the surgery, and to, wean them off afterwards. For a typical like elective case of surgery that we're having, so I work a lot with sports medicine, and we'll give people maybe 7 to 10 days of pain medication. Part of that is dictated by insurance. Part of that's dictated by the patient. And, patients end up acting differently. You give someone, you can do the same surgery on 2 people and it look almost identical. And one person will need 2 days of pain medication and be done. Usually the first 3 days after surgery are the worst for a patient, but, and then they get over it and they're getting better, and that they're able to manage it with things like, ibuprofen or Tylenol. And then others are, they kind of get in this vicious cycle where they get a little bit of pain, they take a pill, they just continue down that path of any little bit of pain is just they're not willing to tolerate. And then they end up on it for weeks or a month at a time. So everyone's different. I do think that if you have people who have more of you said, are there genetic reasons for people to have addiction? And I think the human brain is sort of wired for addiction. A part of like your evolutionary biology has driven us to be reward seeking individuals who are, more willing to take risk and, accept those rewards. And the whole like frontal lobe and reward pathway is designed to be an addictive personality. So, something like alcohol use or opioids, anything, the reward of taking it, the relief of taking it, the brain has basically been designed to do. So, genetics aside, it's very likely for anybody, just being human. I do know that being a male puts you at even greater risk for that. I can't exactly comment on why that is, but it's one of those factors that people find. And male and female drug use differs a little bit, and we can get into that a little bit later if we want. But being human is the main factor that makes us addicted to things. And then in terms of like what our practice gives patients, more often than not, we use a medication called Norco, which is like a Vicodin, which is a mixture of hydrocodone and Tylenol. We typically give that, and then hopefully over time we're able to change them to either just Tylenol or to an NSAID like ibuprofen for pain control. I really focus on making sure patients are using other things for pain control. So after surgery, you get a lot of swelling in your extremities that have had surgery on them or had a procedure. So, trying to reduce their swelling, trying to reduce the pain with things that help numb the area, like ice. Ice can be a really effective modality for just reducing pain a little bit. So even if you get people's scores to notch down 1 or 2 points, you're really making a big difference long term and whether or not they're going to end up needing these medications. The scariest ones are when a patient has a history of addiction or substance use, and you're trying to figure out how to properly prescribe medications for them. And I'd say that has to really be decided with the patient, with their primary care, and between you and them as well, just to make sure that everyone's on the same page of how you're going to handle it, so that, when something does go wrong, you have your answer for how you want to do things. It's better to have that planning in place beforehand than someone to be contacting you 6 months after a surgery, still trying to get more medication when they're the only patient in that group that's had that kind of surgery who's getting it at that time. You really want to help prevent that. And starting early is the key to that success.
Okay, I see. And that was actually my next question, which was if you had a patient who was already addicted to different medications, whether it be opioids or benzos or anything, like would you consider things like tramadol or other types of lesser effective, I guess, opioids? Or would you just skip the opioids altogether and try to go to the NSAIDs and those kind of medications?
Yeah, it really depends on the surgery too and the situation. So I can't give you any blanket rules here that are going to apply. Not particularly for something like a board exam or step one. Certainly if a situation where you might see like a step one question where a patient presents to the emergency and they have a history of like a substance use or an opioid addiction. And they come in with like a broken arm, and basically the conclusion that you've drawn is that they broke their arm with the hope of getting opioid medication or something. And, those are cases where you may consider not giving the medication to the patient to, help get them, even though that's what they need. It's just because they've resulted to this self-injury to acquire the medication. That's feeding that by giving them what they want isn't really going to help the situation. You obviously need to fix their arm and you do need to treat their pain, but using the opioid or whatever they're asking for to do so might not be the best use. For different surgeries require different amounts of pain control, obviously. So, one of the instances where I've seen a patient with difficulty with medication afterwards, they had their hip replaced and they were just dealing with a lot of continued pain. They're about 3 months out and, they're just having those detox-like symptoms. And, I think if you've already had a conversation, it's a lot easier to make sure that they're aware of what's going on. And, talking to them about other medication use and weaning them off is the most important thing. So, in those patients, I typically would try to get them on a lower dose or lower form of the medication like tramadol or something, just ibuprofen or just Tylenol, just to help reduce their opioid use. And if they're addicted and they're experiencing withdrawal symptoms, they're not going to want to just cold turkey stop these medications because they're going to experience a lot of symptoms. And while those symptoms really can't cause death in most people, they really can create a lot of problems and a lot of pain. And most people are just so miserable that they need to use the medications again. Do you know like the basic signs and symptoms that people have when they're withdrawing?
When they go through withdrawal, they get like irritated. They have flu-like symptoms. They have like their pupils dilated. I'm trying to think. Yeah, I remember like agitation, flu-like symptoms, GI symptoms, because opioids cause like constipation. So then they would have diarrhea, and a few they would get tachycardic, hypertensive, things like that.
Exactly. And I think, there are plenty of these that we could go through, and I'll leave it for if we get a question on it, I can kind of help make it easier for our listeners just to remember, which symptoms go with overdosing or withdrawal. But I'll save that. But yeah, if you have those kind of flu-like symptoms, the, anxiety, the irritability, and you mentioned some of the autonomic symptoms as well. Those are all good signs of withdrawal. Yes.
Yes. And I really like what you said earlier about human beings all being having very addictive personalities. I think that's very true. And our brain makes our own opioids as well, the beta endorphins, the enkephalins, things like that. So it's really crazy that we have these being made in our brain, and then we need exogenous ones as well in order to, I guess, satisfy our addiction. And in regards to the actual mechanism of action and the pharmacological pathways, do you have anything you want to add about that? Do you want to talk about like how they work or anything specific?
I think if we have any questions on it, we can go into that. What I will say is another, one of the things that I think doesn't come up very often with pain control is the use of SNRIs. And, when you kind of look at these patients who have exhausted pain control options and they're looking for opioids or they're looking for something stronger, and as a doctor, your suspicion is that they should not be using these in any way at this point, SNRIs can be a good alternative for these patients. So duloxetine, I think there was a trial where they looked at duloxetine and a placebo for pain relief, and they found that people that were taking duloxetine actually had a very significant reduction in their pain levels, some as high as 50% just with the use of that medication. And I think that gets really back to the fact that, we don't have a pure understanding of how these medications all work. Obviously, if you're using an SSRI, there are some medications you have to avoid with opioids. But in general, the thought that you might get some tickling of mu receptors or pain control from serotonin blocking or norepinephrine blocking is not unreasonable to have like a hypothetical situation where that would be reasonable to have or occur. So there are other ways to control people's pain. There are like the nerve stimulators or the TENS units as well that provide just some ways of, kind of overexciting nerves and leading to a reduction in pain because it just sort of, your brain just sort of tunes it out after a while. And, for skin things, you think about like the capsaicin creams or something that kind of leads to a numbness after a while as well. So there are other ways to treat pain. It's really important to know where their pain is coming from and is there another way that you could be potentially treating it as well?
Yeah, you're absolutely right. Alternatives are very important to consider, especially with this kind of, opioid crisis. So hopefully they have more research being done on this. So that way, like in the future, we have other less addictive alternatives to pain medications.
Yeah, there was an exciting drug there's some exciting news recently about a new class of pain control medication. And that's coming down the pipeline. And I guess we'll see if that actually turns into anything. But if we do have other ways to treat pain, then, depending on if it has an addictive quality or not, which, hopefully the prudent research will show whether or not that's the case, then maybe we'll have some other tools that are in our arsenal to really kind of fight things like pain and prevent things like opioid abuse.
Yes, hopefully, fingers crossed for that. Do you want to do a question? I can read a question and then we can...
Yeah, absolutely.
So the question is, a 37-year-old male presents to the clinic for treatment of an opioid use disorder. It is his first appointment with you, and he states that he last injected heroin 1 hour prior to his appointment. He reports a past medical history of a fractured pelvis sustained in a car accident 2 years ago, after which he was placed on oxycodone for pain control. Other than that, his past medical history is unremarkable. Other than an elevated blood pressure in the office this afternoon of 140/80 and some dental caries, his physical exam is normal. In terms of his previous pain management therapy, mu receptors mediate which pharmacodynamic effects in the CNS. So is it A, euphoria and pupil dilation, B, analgesia and respiratory depression, C, coughing and sedation, or D, decreased oxygen saturation and increased heart rate? So when you see a question like this, it's basically just asking about when the mu receptors are activated, how does that affect the CNS?
Yeah, that's essentially the gist of the question. It's very straightforward here, depending on if you know the receptors, but just to kind of make it a little more complicated, let's go through it. So in general, this patient, this is kind of the classic situation that I was talking about with the case of surgery. He is coming in to be treated. He's just been using heroin recently. Heroin's actually not that commonly seen in its pure form. Most people are getting their hands on things like fentanyl or something else if they're using street drugs like that. But for the purpose of these kind of questions, you may see something like heroin. So he previously fractured his pelvis in a car accident, and that's why he was placed on the pain medication. It doesn't say whether or not he had surgery for that, but if he did have surgery, that's a very significant fracture. That's a big surgery. So it's not unreasonable that he would be placed on that medication for oxycodone just to control his pain afterwards, regardless of whether or not he had the surgery. if he had fractured his pelvis and he wasn't placed on a medication, he may have avoided this kind of situation. But, at the same time, you're trying to make people comfortable after these kind of injuries. So it's not, they weren't wrong for putting him on this medication, right?
Right.
It's just the fact that he wasn't able to come off of it and he may have been lost to follow up. You'll find that trauma patients in general, he's a car wreck, but you're not really sure about his demographic. But sometimes you get these trauma patients that just don't always show back up after their injuries. And you gave them a very large prescription of this medication and sent them on their way. That could be the situation that leads to an addiction, and they may have gone to other providers with similar complaints in order to continue that until they ran out of the medication, at which point they kind of turn to these more street medications like heroin. So for him, he's a little hypertensive. He has some dental caries. So that's just kind of showing him as in a bit of a disheveled place with the dental caries, but nothing here that's terribly remarkable. And then this is kind of what you'll find is this is called a pseudo question, where they give you all this information and then they ask you something that's not really related to it. So here it's asking about the mu receptor mediating, which, sure that you could say his previous medication is related to that, but it's kind of a false question almost.
Right. You could just read the last line and answer the question.
Right. So the vignette doesn't have a whole lot of significance here. A better question might have been like, in terms of this patient, how should his pain medication have been managed or something? But that would be a longer answer question too. But anyway, getting back to the mu receptor, there are 3 kinds of receptors in the brain that handle endorphins, right? Do you know the 3?
Mu, delta, and kappa.
Right. They're all Greek alphabet letters. So whether or not that matters, mu receptors are the ones that are considered the primary pain receptors. And they help with, giving the endorphin response to relieve pain. So analgesia is going to be your obvious answer. The less obvious one, but also making sense here, is respiratory depression. And while I don't remember the exact pathway that mu receptors act on the respiratory center, it does depress it. And having more mu activation can lead to a decrease in the respiratory rate of a patient. This doesn't necessarily lead to a corresponding decrease in their ventilation, but they do breathe slower. So interestingly, calling it respiratory depression, until they're in an overdose state, they're really quite able to ventilate on their own. They're just breathing slower and deeper.
All right. And for board's purposes, it also would cause a rise in the carbon dioxide. It could possibly lead to intracranial pressure, an increase in ICP. But yeah, that's aside from this question. I just wanted to throw that in there.
Right. So euphoria and pupil dilation, what does that make you think of?
So pupil dilation, I normally think of cocaine for that, and same for the euphoria. I believe, or some sort of withdrawal, but I don't think you have euphoria with withdrawal. So either for the pupil dilation, you'd be withdrawing from an opioid, or you'd be on cocaine. Yeah.
The other one I think about is MDMA. And then coughing and sedation, what is that? Does that bring anything to your mind?
No, I can't think for coughing and sedation.
Decrease oxygen saturation and increase heart rate. Those are pretty autonomic. So, you could have those with a lot of different things, but you may see it in something like an overdose. And then diarrhea and elevated blood pressure. Does that give you anything in particular?
For diarrhea, I would think if you're withdrawing from opioids, or I know certain amphetamines can cause it, withdrawal of certain drugs can cause it.
Yeah. So exactly, like an amphetamine, or I think a withdrawal from an opioid. So like the mu antagonist instead of mu agonist could cause these symptoms. And I'll kind of get into the differences here, that the way I like to think about opioid intoxication and withdrawal, I kind of see them as opposites, two sides of a coin. The easy way to think about it is when you're withdrawing, everything really opens up. And when you're intoxicated, everything really closes down. So let me walk through that to make that a little bit more clear. So when you're intoxicated, everything's closing down. You're drowsy, you're constipated, you're lethargic, your pupils are constricted, your respiratory rate is depressed, those sort of things. So everything kind of goes down in the drive. Pupils get smaller. So everything seems to be moving in the direction of lower activity. And then when you're withdrawal, everything is kind of reversed. So you're agitated, you're anxious, you can't sleep, rather than having constricted pupils, you might have really dilated pupils. You get those kind of sludgy symptoms where your eyes are watering, your nose is running, you're yawning, you're opening up your mouth really wide, right?
Right.
You have fever, you're really unable to eat or anything, and your blood pressure goes up, your heart rate goes up. Your pain goes up. So all of those things kind of, to me, feel like opening up or elevating, whereas intoxication is depressing. I think that's a helpful way to remember it.
Yeah, that's a really good way to remember it, honestly.
And that goes the same for mu agonism and mu antagonism. So a patient that you're giving a Narcan dose to might experience some of these antagonistic or opening up signs and symptoms. And that can actually tell you that maybe you've done the right thing for them in terms of helping with their respiratory depression when they're at a very high level of opioid overdose.
Okay, I see. Thank you for that. That's a very good way to pose. Do you want to talk about how we would go about handling opioid intoxication and opioid withdrawal?
Yeah, so this has kind of become more of a provider, a first responder role, but it can certainly happen in the emergency room, or if someone ODs right there in the hospital too. In the worst case scenario is like a patient got way too much medication for some reason, but what you might see in those cases is they're incredibly drowsy. They're not really making much sense. Their speech is slurred. They look like they're falling in and out of sleep, and their respiratory rate is extremely low. If their pupils are all constricted, they don't seem to be alert and rousable. Then you're concerned that they're going into a coma and could proceed to have something like a poor outcome, like death.
Mm-hmm.
So when you see those patients, you have to have a differential for why that's going on. And certainly there could be other reasons other than just opioids. But if you have a younger patient with this sort of situation and they don't have any reasonable past medical history that would assume a situation like that, and they don't have anything like a brain mass or something that could cause these symptoms in another situation, you can almost quickly identify that it's opioid related and start to treat the patient.
Right.
And you're going to treat this like any other trauma or quick first response patient, where you're going to start with your ABCs. You're obviously going to make sure that they have a secure airway, make sure that they're able to breathe, make sure that their pulse is running, everything like that.
Mm-hmm.
In the case of these patients, the sooner you identify them, the sooner you can give them a dose of naloxone or Narcan. And when you give them naloxone, you'll see that their respiratory rate will improve pretty dramatically.
Okay.
In some cases, they may have extreme pain, or they may just rouse a little bit more. But their O2 and their saturations are going to improve. And if they don't, there are two situations that you can think about. You can think about that they've either had such high of an overdose that they need more of the medication, or something else is going on. Okay. So some patients will get multiple rounds of naloxone therapy, and as it wears off, if they have a lot of opioids circulating in their system, they may fall back into these overdose kind of signs and symptoms as well. So the naloxone can potentially wear off, and then the patient become resedated.
Right.
So ultimately, you have to carefully watch them. You may consider putting them on a ventilator or something just to suppress their, to support their ventilation. But and then you're kind of treating them symptomatically to work on their blood pressure. Their autonomic system is kind of going to go haywire as they withdraw from opioids, and kind of sedating them, controlling the pain in different ways. And making sure that they don't have any other problems going on is going to be an important aspect of that.
And just for the board's sake, I think I just wanted to add naloxone to our listeners. It's the inverse agonist that binds to the mu receptors, normally used to reverse opioid overdose. I believe it's given IV, and I believe you'd want to give it slowly, right? So they don't start to go through a withdrawal syndrome, or is that you would want to give the IV naloxone a little bit slow?
I'm not totally aware. I know there's also a nasal formulation of it. I'm pretty sure that you just give it all at once especially in the first responder kind of situation. I don't think that they have they don't titrate it or anything like that. I think they just administer the dose, at which point you will see whether or not it's affecting the patient at that point. Like I said, they may need multiple doses of it, but it's going to hopefully, like you said, it's a competitive opioid antagonist. It works on all the opioid receptors, so not just mu receptors, which is, kind of, I guess, a little tidbit fact. And then, it's mainly for reducing or reversing the opioid toxicity when they're overdosed.
Okay.
And then, naloxone is the Narcan, the kind of first line therapy drug. And then there's also naltrexone that we could talk about. There's a pill form of naltrexone and a intramuscular injection form of naltrexone. That's for more of a maintenance therapy.
Mm-hmm.
You can use it for overdose, but it's not as effective. It's not as fast, and it's harder to administer.
Okay.
So it may be easier, the Narcan is kind of your first line, and then you may put someone on naltrexone as a way to keep them off opioids long term.
Right, exactly. And what about for the withdrawal, would you consider buprenorphine, methadone? How would you tackle if someone was going through opioid withdrawal?
Yeah, so I mean, there are different ways that you can treat withdrawal, and the way that we're currently kind of doing it is we're titrating out the withdrawal to kind of put it over a long period of time, but depressing the symptoms enough that a patient is able to kind of get through it without having that terrible cold turkey kind of feeling. What that results in is a lot of patients getting a long-term dose of these medications before they're really able to kind of come off it altogether, right?
Right.
So, the thought of using methadone is methadone has it's a long-acting opioid antagonist. So it's a full mu agonist. It's long-acting, and it will suppress those withdrawal symptoms. It's harder to overdose on it, but it is still a very dangerous medication if you get a large dose of it, particularly because the effects don't wear off for a long time.
Right.
So, you potentially can give a patient a dose of it, and then they have good control. They're not having symptoms, or they're slowly tapering on those symptoms. So they have only mild symptoms of opioid withdrawal. And then you have them kind of decrease those doses as they are able to not experience the symptoms anymore. And the goal is to get them all the way down to zero and no longer using an opioid. Methadone is the ideal one for step if they're pregnant or have a child and they're trying to control for opioid dependence. We typically use methadone.
Oh, okay. So pregnancy, methadone. Okay.
And then there are, buprenorphine and Suboxone, which is buprenorphine plus naloxone therapy. are two other kind of options. Most, it's not as often that you see someone on just buprenorphine, but that's a partial mu agonist. It similarly has that kind of long-acting affinity. But because it is a partial mu agonist, they could potentially, if they're still taking opioids, they could just use it as another opioid.
Oh, so that's where you give the naloxone with.
What we were finding is that people were just using that kind of as with their opioids. It really wasn't working as well to get people to decrease their use of it. Being a partial mu agonist, though, is a little bit safer than like an opioid, because it can't cause as much like of the overdose like symptoms. It can't have that full effect like methadone could, but it could be combined with other medications and it's just not as helpful. Suboxone, therefore, kind of added this naloxone therapy with the buprenorphine. So that's an antagonist and a partial agonist. And, I think the way it works is it gets you a little bit of the antagonism, which prevents you from taking another medication and getting getting those effects of an overdose. But what they can cause is if you are using it and you've been taking an opioid, you could precipitate withdrawal by taking the naloxone, right?
Right.
So one of the keys to taking it is that they have to be off opioids for a time period before they can start it.
Oh, okay, I see.
But if they have started it, if they've made it to the point where they can start that medication and continue it, potentially, as long as even if they continue it indefinitely and then they use an opioid because they lapse, they're not going to have the endorphin effect of the opioid, and potentially will not relapse.
Okay, that makes sense. Do you have anything you want to talk about in regards to neonatal abstinence syndrome?
I do not. I mean, we can talk a little bit about it, but ultimately, you're treating the kids get better, and I do think they use methadone in some of those kids.
Yeah, I think they use morphine, PO, and then second line phenobarbital or clonidine.
Mm-hmm.
Looks like it helps with some of the withdrawal symptoms.
Yeah. So clonidine, do you remember what kind of drug that is?
The alpha-2 agonist.
Right. So being that it lowers autonomic symptoms, right?
Mm-hmm.
By blocking them. By blocking the alpha-2, and that can help decrease some of the unpleasant like autonomic symptoms from opioid withdrawal. It does get used some in adults as well, but it's typically not as important, I guess, for this kind of discussion here.
Okay. Yeah, we'll go ahead and do the next question. So a 52-year-old male presents to the ED with suspected opioid overdose. His friends call the ambulance, which transported him to the hospital. Naloxone was given in the field, which reversed most of the symptoms. At this time, he is still disoriented and is unable to answer questions. A person experiencing an overdose of this type would be most likely to exhibit which of the following triads of signs and symptoms? A. Mydriasis, dry mouth and sedation. B. Euphoria, tachycardia, calmness. C. Shallow breathing, unconsciousness, and meiosis. Or D. Itchy skin, rhinorrhea, and confusion.
Okay. So just to kind of go over this again, a 52-year-old, he is suspected of an OD. He was given naloxone, which reversed the symptoms, but it doesn't tell you what the symptoms the patient had, right? And then it asks you, what would you expect? So we already kind of hit on this earlier. I talked a little bit about the opening up of withdrawal and the closing up of overdose. So, the things that we think about for closing up, you have that depression, that lethargy, or you may drift out of consciousness or have an altered mental state, and, respiratory depression, pupils get constricted, et cetera, et cetera.
Right.
So in this case, mydriasis is open, dilation of pupils, dry mouth, and sedation. The sedation works, but the other two, aren't really associated with overdose. Do you know what that's referring to?
I'm not sure, actually.
So I think this is referring to marijuana intoxication. And then, so mydriasis, pupil dilation, dry mouth, and then sedation.
Okay. For sure.
Yeah, and I mean, I'm putting it more on the dry mouth and sedation. I'm not as sure about the mydriasis. And then euphoria, tachycardia, and calmness.
So we know that you wouldn't be tachycardic. Calmness, I'm not sure if that means they're very zen or if they're just, close. I don't know.
I mean, that's how I take it, though.
Okay.
And then euphoria is just pleasure. So, tachycardia, euphoria, calmness, this is like an MDMA.
Okay.
And then itchy skin, rhinorrhea, and confusion.
I'm actually not sure about that one. I don't know which one would cause itchy skin unless it's a withdrawal. I don't know. Or is this like the one where we like feel like there's bugs crawling on us? Is that what they mean by itchy skin?
Yeah, well, it goes with that, I think. Yeah. So I'm just going to double check here. I think it's is it PC? I was thinking of PCP. Itching skin can come from a lot of things. Opioids can cause it. Yeah, but the one that I was thinking about, and it's kind of noted here, is itching can be related to mu activation. It can cause like a histamine release, and they see that often with morphine.
I see, having like an allergic reaction.
Mm-hmm. And in like a neonate, you also see this. Like these are symptoms that you might see. Okay. If they've had an opioid intoxication.
Okay.
But the answer that this one kind of goes in is going to be C. It's shallow breathing, the unconsciousness, and the meiosis, right? So the small pupils, they're not rousable, and their respiratory rate is depressed. That's like the typical triad that we're talking about. Your alarms in your brain should be thinking, oh, maybe this patient has OD'd.
Exactly. Whenever I see meiosis, I just think opioids, but sometimes like the other ones for sure also are important.
There are a couple of opioids that don't cause the meiosis. Let's see. Which one am I thinking of? Demerol. Meperidine.
Oh, okay.
It doesn't cause meiosis.
So meperidine does not cause meiosis, right?
Yeah. So Demerol, which is an exception, and exceptions make great test questions.
Ah, I see. That's good to know. Let me see if there's anything about tramadol that's important. So
tramadol is a good medication, right? Because it's a weaker mu agonist, so it doesn't have as good of opioid kind of effects, right?
Right.
But it's also a serotonin blocker. So the contraindication to a tramadol use is a MAOI or SSRI use, because that can cause serotonin syndrome, right?
Right. That makes sense. Okay, so I think that's very important about tramadol. So it inhibits serotonin reuptake, so it can potentially lead to serotonin syndrome.
Yeah.
Okay. No. And it can cause seizures apparently too.
Yeah. The CNS side effects are fairly common.
Okay. Are there any other special ones you want to talk about?
Those are good. The other, because one of the symptoms of opioids is constipation, we've, kind of leveraged that side effect for patients who have diarrhea. And that's what loperamide does. Mm-hmm. So loperamide is a medication that actually doesn't really have much CNS effect. But it does have a effect on the GI system, and like other opioids, it kind of slows gastric motility and can lead to constipation, which is the goal as an antidiarrheal. Okay.
Loperamide and I think diphenoxylate, right? Diphenoxylate was the second one. So yep, that's true. It causes decrease in intestinal fluid secretions, leading to it stops basically diarrhea.
Yeah. I mean, and that's an easy one to put together because that's like a side effect of taking opioids, right?
Right. I think another one is dextromethorphan, which is given for cough.
Right. So that's the main ingredient in cough syrups.
Mm-hmm.
And that works as a cough suppressant.
Okay. That's the weak opioid receptor agonist, also NMDA receptor antagonist. And that one also inhibits serotonin reuptake too.
Right.
But yeah,
so that's another concern.
Is the cough suppressant.
And then the fun fact about it is that if they're taking it, it can cause a false positive on their urine drug screen for PCP.
Oh, wow. I did not know that. Good to know.
Yeah. It shouldn't come up for an opioid because it's like a synthetic opioid that doesn't get tested with the urine drug screen.
Wow.
Maybe newer ones, but like the typical.
That would be awful if that happened on a drug test to anyone.
Yeah. Yeah, exactly.
Do you have any other tidbits you'd like to add? Do you want to talk about anything else? Let's
try to do one more question.
Okay.
Let's see. So we already hit on these other questions with the stuff that we talked about. So I don't want to waste anyone's time and go through them again. The way we could do that is we could just read it and then they could have someone move it ahead. But we kind of already talked about the naltrexone. You had to wait before you start it because of the symptoms and the withdrawal. And then the clonidine for symptomatic relief, right?
Mm-hmm.
I think those are good for the questions, unless there's one that you like and you want to see.
No, I think those are good.
One thing I didn't talk about in this question here is it asks about you need to monitor LFTs. Mm-hmm. Naloxone and Narcan can cause hepatotoxicity.
Oh, okay. So naloxone, Narcan can cause hepatotoxicity. So that's why you'd want to monitor their LFTs. Do you know how often, like this is just random, but do you know how often we would monitor them after we've been giving them naloxone?
I don't. I imagine they actually have like a amount of time but I think you're going to want to you're going to want to check them before and then like a month after. And then maybe, I don't know if they need monthly monitoring or if you can do it, you can space it out afterwards. So I'm not totally sure about how they like to do it.
Okay, no problem. Let me see. Do you want to discuss the ceiling effect in regards to opioids, like certain ones that have it, certain ones that don't? For example, morphine, it's the full opioid receptor agonist. It doesn't have an upper limit, so there is no ceiling effect. So basically, if you have an increased dose, the more you increase your dose, the more response you'll have, and there's really no cutoff point for that. Whereas for a partial agonist like buprenorphine, it does have an upper limit. So after a certain point, no matter how much you increase the dosage, it doesn't increase the response, but the side effects do get increased.
Yeah, so
ceiling effects.
The importance for the ceiling effect, I think, is for respiratory suppression, right? So what you'll find is if you take too much drug, you can overdose. And if you take enough of it, you can stop breathing. That's where these overdoses really kind of pivot on, is when people stop breathing, they die. So the ceiling effect is most important for someone who is taking a medication or taking a drug and getting those effects from it, the high. And then over time, they need more drug to sustain that same high or achieve that same feeling, correct?
Yes, correct.
So what they end up doing is they take more and more, and then they may have more and more effects. The other situation there is then if someone ends up off the medication for a long period of time, or they go through a withdrawal and now they're relapsing, their body isn't used to tolerating that amount of the drug, whereas before it kind of had upregulated the enzymes to help clear it. In this case, they take the medication dose at the doses that they were taking prior to their withdrawal, and because there's no ceiling, they keep going, and their withdrawal or their overdose is much stronger than it previously would have been, and that's how they end up passing away. When their respiratory suppression leads to complete apnea, right?
Right.
You mentioned that some medications have ceiling effects and others do not. My main understanding of it is that things that are partial are more likely to have ceilings and be difficult to lead to a full overdose, whereas things that are full agonists can cause it may not have a ceiling and you can continue up titrating the dose to experience effects.
Exactly. And I think that's where a lot of the deaths occur as well, is people don't realize that, the more they take, their body can't keep compensating for it, and eventually they will pass away from it.
Yeah. And that's a terrible situation. And obviously, like, it's one of those things where you really have to educate the patient that, and I mean, obviously you think the best of your patients and you don't want them to be on a medication, but if they are in the hospital and go off of it and go through a withdrawal or something, for some reason they've withdrawn or no longer on the medication, if they're going to restart it, they can't take it at the same dosage that they're used to taking it at because of those problems.
Exactly. Do you have anything else you want to add in general, overall, about this topic?
Yeah, I mean, it's a really important topic. I think that in medical school, you're taught a lot about asking questions about pain and that we should treat people's pain. And we aren't really educated well about how to avoid these kind of problems. We're just told about them. So, I think the importance of knowing, what are alternatives and how do you avoid using these medications at all cost, is really important for these patients. You'll see patients like sickle cell patients, for instance, and they're going to need medications like this. And you're not to say it's a slippery slope, but it kind of is when you're putting on all of these patients on this medication. You're going to have some that have problems, and looking for it and finding ways to kind of avoid it are kind of key. If you're aware that that's the situation with your patient before it gets out of hand, I think it's more important. The longer you let this thing go, the more likely they are to wind up having bigger problems and not recovering from it.
Exactly. I think you're absolutely right. And I think the biggest thing we learned in medical school also was trying to identify who was purposefully seeking opioids. We were taught, like we've talked about earlier, someone who comes in for their first time about an accident years ago, trying to look for pain medication, saying that they were prescribed opioids in the past and they helped, and, looking for like patients with these kind of drug seeking behaviors. And at the same time, like you said, trying to figure out when we should prescribe them, how long they should be prescribed for. It's a very, very fragile balance, I think. And hopefully, in the up and coming future, they have better pain medications that aren't as addictive as opioids. They work great for pain, but they come at a cost. So
yeah, I think it's important to tell people and help them accept that pain is okay and pain is natural. So helping people understand that they'll have pain is it's a tough conversation, but it's a worthwhile one.
Right. I think it's very important communicating with patients as well. This is another question. A 37-year-old male presented to your clinic as an injection drug user who predominantly uses heroin. He also admits to smoking crack cocaine and marijuana. He's been using these substances for many years. When he cannot get opioids, he will take benzodiazepines, though he clearly expresses a preference for opioids. On initial workup, you find that he is positive for Hep C and clinically does not have severe liver impairment. The remainder of his chemistries, including a CBC, CMP, including LFTs, are within normal limits. He is HIV negative on screening. He is eager to start buprenorphine naloxone treatment. What do you tell him? So for this patient, we discussed that they would need to have their LFTs monitored because naloxone can cause hepatotoxicity. For option A, so buprenorphine naloxone is absolutely contraindicated with Hep C. B, buprenorphine monoproduct is preferred in the Hep C positive population. C, buprenorphine is contraindicated with Hep C. D, buprenorphine naloxone can be started and we will need to monitor LFTs. Or E, the only appropriate treatment for him due to his Hep C is methadone.
Yeah, so This is an interesting question because they tell you the patient has Hep C and potentially has some liver complications, right? The reason that we don't like to use naloxone or Narcan or naloxone or naltrexone in patients with hepatitis or liver impairment is because it has the potential of causing hepatotoxicity, right?
Right. Yes.
So things like buprenorphine are kind of preferred just because it would avoid that potential. However, hepatitis C, if it's not clinically active and particularly if it's being treated and you're doing monitoring, you should be safe to prescribe naloxone for. So that it's absolutely contraindicated with hepatitis C is not true because you can watch for the hepatotoxicity and see if they have any liver problems after starting the medication, right?
Right.
Then, for same reason, buprenorphine monoproduct is preferred. That's sort of trying to say maybe we should use it because it doesn't have the hepatotoxicity. So, but it's not actually preferred. It's just another option. If they do have the hepatotoxicity, you could use the buprenorphine. Buprenorphine is not contraindicated in hepatitis C. So the correct answer here is that buprenorphine and naloxone can be started, and you're going to monitor their LFTs to see if they have any problems with their liver afterwards.
Okay, that makes sense. And the vignette says that he doesn't have severe liver impairment or any remarkable LFT changes. So as long as we're monitoring that, like you said, we would just do the buprenorphine and naloxone.
Exactly. So good question.
Awesome.
And then let me read you one and see what you think here. So a 33-year-old male presents to your addiction clinic with pinpoint pupils and reports using heroin 2 hours ago. He's requesting treatment for his opioid use disorder and reports that he has previously tried both buprenorphine and methadone, both of which have been ineffective. After a full assessment, you determine that naltrexone is an appropriate treatment alternative. Which of the following is the most appropriate course of action when starting naltrexone in this patient? Is it A, provide an IM injection of naltrexone immediately, given this patient's high likelihood of ongoing heroin use and the need to immediately treat? B, provide the patient with an oral dose of naltrexone immediately, wait 6 days, and then provide an IM injection? C, start the patient on oral naltrexone immediately? D, tell the patient he must abstain from all opioids for at least 5 days before initiating naltrexone? Or E, give a dose of the nasal spray naloxone before giving an IM injection of naltrexone? So what do you think, Mariah?
So before I try answering, could you explain to me why we would do the 5-day thing again? Just because I want to make sure I don't confuse the audience.
Yeah, sure. So he just used heroin 2 hours ago. Mm-hmm. So he's on opioids, right? So a patient who is on opioids, if they aren't overdosed, if you give them or anybody who has pain in general, who's being treated with an opioid, if you give them a dose of naltrexone or naloxone, that's going to give them an inhibitor of their opioid. So if they have a reason for that medication, or if they are a user of that medication, giving the antagonist will lead to a withdrawal.
Okay, perfect. I just wanted to make sure that was it. Awesome. Mm-hmm. And they're both it's an antagonist, right? That's why it would
right.
Awesome. Okay.
Yeah. So in this case, you're going to see that if you were to give it right then, they would have a withdrawal episode in your office. And that's probably not the situation you want.
Right. Okay. Awesome. Thank you. Okay. So for this patient, we see that he just used heroin 2 hours ago. So he has opioids in his system. So if we were to give him something like naltrexone, which is an antagonist right away, like an option A, that would actually cause him to go through withdrawal. So we wouldn't want to give him naltrexone immediately. So option A is out. Option B says provide the patient with an oral dose of naltrexone, wait 6 days, and then provide an IM injection. So that's also out. Option C says start the patient on oral naltrexone. So that's also out. Regardless of the IM injection or oral, we don't want to give them the antagonist right away. And option D, which is the correct answer, You tell the patient that he must be abstinent from all opioids for at least 5 days before initiating naltrexone. That way it should be out of his system, and initiating naltrexone won't induce a opioid withdrawal in this patient.
Yeah. So in this case, they need a withdrawal clinic or something before they start the naltrexone, just because you're trying to avoid the situation where you give them the medication and then all of a sudden they're in terrible with complete withdrawal.
Okay, that makes sense. And it wouldn't matter if it's a nasal spray or IM or oral. We just wouldn't want to give them anything right away.
Yeah, if they're not overdosed. So imagine if a regular patient comes to your clinic and they've had surgery and they're on an opioid. That's, a reasonable thing for them to have. And then you were to just give them a dose of naltrexone just because. You wouldn't, but if you did, then all of a sudden all their pain control from the medication would be gone. And they would be having terrible symptoms and terrible pain or terrible withdrawal if they were, a little bit addicted, anything like that. So you would avoid that because you don't want the patient to unnecessarily suffer. And by giving them time for their opioids to leave their system before you start the medication that's going to antagonize the opioids. After which, if they use the opioids, they're not going to get the same kind of relief. But you want to get the opioids out of their system so they don't have those immediate withdrawal symptoms right before the medication.
Okay, that makes sense. So another question we have is a 23-year-old female with a history of opioid use disorder, currently on methadone maintenance therapy at a dose of 120 milligrams daily, presents to your family medicine clinic in a state of opioid withdrawal. She explains that she has an upper respiratory infection for the last 2 to 3 days and has been unable to go to the methadone clinic for the past 48 hours. Your exam reveals a resolving viral bronchitis and moderate opioid withdrawal. She's requesting to be provided with a 1-day prescription for methadone, given that the clinic has closed for the day, and assures you that she will re-engage with her methadone program tomorrow. She has provided documentation verifying her dose. Which of the following is the most appropriate course of action? A. Provide symptomatic relief for the patient's withdrawal symptoms with clonidine. B. Provide the patient with a 1-day prescription of methadone, given that this is permissible by law in your state. C. Switch the patient to buprenorphine maintenance therapy. D. Provide the patient with half of her methadone dose in a written prescription. Or E. Start the patient on naltrexone.
Ooh, this is a good question. Yeah. Okay. So this patient has previously been on methadone for a while now, and now they're in withdrawal. They're taking 120 milligrams of methadone, which doesn't probably mean much to you, but that's a sizable dose. That's not they're not quite ready to stop methadone. And looking at it, they've been unable to get their methadone dose for 2 days now. So they're because this is a long-acting opioid, they may get 2 days of relief before they start having withdrawal. So in this case, you're probably not able to give them methadone, but it really depends. But the best thing for them to do is just to get back into the system and not double dose their methadone. Because if you give them methadone whenever they're in the clinic, say this is like the afternoon, you give them their methadone dose and then they go to the methadone clinic tomorrow, they may get too much. That makes sense?
Yes.
Because the dosing is pretty fickle for methadone. So what you should just do in the meantime is try to give them some symptomatic relief until they make it to the clinic. They're not going to be totally detoxed from methadone by then anyway, so they should be okay. That is a reasonable thing to provide them relief, and just give them the clonidine, which is we talked about. Has alpha-2 effects, so it can reduce some of the irritability, some of the autonomic symptoms associated with withdrawal, right?
Right.
The other options, switching the patient to buprenorphine therapy, that's an option. You could start them on something else, but unless they're going to start following up with you for that and stop the methadone, it's going to be kind of iffy. And buprenorphine, because it's a partial agonist and you give it with methadone, I'm trying to think if this is correct, if it can cause some withdrawal symptoms because it's only partially agonistic. right? So like if it captures those receptors from the full agonist, then it's also going to cause some withdrawal for a patient.
Right. Yes, it does. It does like displace other opioids from the receptor. So
yeah. So you don't just switch a patient to it. And then having the dose is, kind of trying to work the system with the, like, we want to give her some, but not the full dose. It's probably just more difficult than it's worth figuring out. Plus you probably can't give it and you probably don't have it to give.
Right.
And then starting the patient on naltrexone. So we already talked about the opioids you having to be kind of detoxed from before you start the naltrexone, or you'll initiate a full withdrawal. If she was really, pretty far along in her withdrawal, if she had come in and now it's been a week since she's had methadone and her opioid symptoms are starting to maybe subside, then she's basically withdrawn from methadone. There's no point in restarting her on methadone at that point.
Right.
Because now you're just giving someone opioids for the sake of it. And the whole point is that we get them off of it.
Mm-hmm.
So, you could potentially give someone naltrexone after they've detoxed to make sure that they, if they were to re-engage with opioid use, then they wouldn't have the benefit. But this patient isn't far enough along for that yet.
Makes sense.
Well, Mariah, thanks for talking with me about these. This was a good discussion. I know it's an important one for the podcast. Hopefully this gives us a couple episodes that we can talk about. I know it's a really, critical topic that people should be interested in knowing more about.
Thank you so much for your time. I learned a lot. I hope our listeners learn a lot as well. And I think that's all we have for today. And thank you everyone for listening.
We really appreciate your time and you enjoying our podcast. If you really like it, share it with your friends and give us a rating on iTunes. That's always really helpful. We have an application where you can get all of our latest episodes as well as access to our all audio Q bank. And feel free to give us a rating on there as well. It's really helpful. And have a great day. Happy studying.